been doing, and this is the anterior and posterior load and shift test. So for this, we're going to find the head of the humerus, we're going to load it, push in, we're going to move it forward and backwards. A positive test for this would be movement greater than 25%, and that would show glenohumeral instability. And for this, we're going to want to test bilaterally as well.
I'm Shane Yoho. This is the apprehension test, and for this, you'll bring their arm up and then stabilize here and rotate backwards to see if there's any apprehension, and this would be pathology for instability anteriorly.
Here, Richards, we're doing the posterior apprehension test. So I'll bring the elbow up 90 degrees and then load it, and we'll be looking for apprehension, and that would be indicative of posterior instability.
This is Mitchell Bunn, and we're doing the sulcus sign test. So what we're going to do is take the arm and we're just going to pull it down. And if there is a visible dimpling or a divot right underneath the acromial area, then it's indicative of inferior instability in the.
This is the shear test. For this, you would find the spine of the scapula and the clavicle, and you would press in. This is looking for pain in the AC joint, which would be a positive test for AC pathology. The sternoclavicular joint integrity test. For this, you would find the SC joint and move a little bit lateral. You'd be pressing down on the clavicle, looking for laxity, and a positive pathology would be a sprain in the SC joint.
Drop arm test, we'll have the athlete bring their arms up above their head, with their palms facing out, and have them slowly lower their arms to their side. And while they're doing that, we're going to look for any pain or uncontrolled movement, and that would show be signs of a rotator cuff injury.
We're doing the empty can test. What we'll do is we'll have the athlete bring their hands out at a 45-degree angle, and then we'll load it superiorly, and they will push against that resistive force. And we'll be looking for any weakness, and that could be indicative of a supraspinatus injury.
Infraspinatus strength test. So what we're going to do is have the athlete bring both their arms in, tucked in at their side with their elbows there, and I'm going to provide a resistive force, and they're going to try to push out against my hands. If there's any weakness, then it's indicative of infraspinatus pathology.
This is the speeds test. For this one, we're going to have the client put their arms straight out like this, and you'll be putting resistive force here and have them lift up. For this, you'd be looking for weakness, and a positive test would be weakness for the biceps brachii.
Now we'll be doing the pectoralis major contracture test. So we'll have the athlete lie in a supine position. They'll put their hands behind their head and relax. And what we'll be looking for is the elbows to hit the table. If they don't, that would be a positive test indicative of tight pectoralis major.
Hawkins-Kennedy test, looking for shoulder impingement. So what we're going to do is bring their arm up to 90 here and take their forearm. We're going to slowly internally rotate that. If that causes any pain there, then it'd be indicative of a shoulder impingement.
The crank test, we'll have the patient lie on their back. And we're going to take their arm, bring it up to about 60 degrees. We'll push in, and then we're going to externally and internally rotate the forearm, rotate the shoulder there, and we're looking for any painful clicks or pain at all that would be indicative of a labral injury. Next, we have the compression rotation test. So we'll grab that arm, we'll push in and externally and rotate, externally and internally rotate shoulder, and we're looking for any pain that would be indicative of a labral injury.